Hello, world. My name is Dr. Kulmeet Kanlas, and today in this live podcast, we'll be discussing about chronic pain in elderly or our senior patients. This topic is very important and very relevant, and I think there is a lot of miscommunication around this topic, lot of expectation problem, lot of misconceptions about what we could do for this chronic pain and what is the goal of treatment. I think we all are mixed up, and in this podcast, my goal is to provide you with a clear pathway to understand about chronic pain, what we can offer, and what we could accomplish as we go through this treatment. Pain is a very, very important symptom. In a primary care practice, about 30% of the patients or 30% of patients we see have one or other kind of pain. And I'm not talking about pain which is due to cancer or rheumatological disorder. Because pain at end of life, also in cancer and rheumatological diseases, is altogether a different beast, and we categorize them into a different bucket. We are talking about normal community living seniors who are active. They are trying to stay in this game of life, and they have chronic pain. And most of the reasons for those chronic pain is degenerative. So I want to clarify that we are not talking about cancer pain in this one. We are not talking about rheumatological pain. We are not talking about end of life pain. We are talking about classically pain which is degenerative in nature. Estimates are that 25 to 50% of seniors are living with moderate to severe pain on daily basis. Look at the magnitude of problem. United States is getting older. The proportion of people who are 65 and above is increasing at an enormous rate, and out of them the population 85 and above is increasing significantly. So we have a crisis on our hand. We had a very difficult experience in the office for last couple of days. We happen to have some patients who are in pain. I do not ever undermine anybody's pain, but they didn't want to understand what pain medications do to them and what is the specific goals are. And they were really upset with me. And this podcast is dedicated to them. My goal and hope is that they will listen to it and hopefully have a better understanding with a clearer mind at this time rather than when they were emotionally charged and they didn't want to hear me. Pain is a protective mechanism, and pain is of two kinds: acute pain or chronic pain. If you look at our seniors or anybody who in fact who is have a chronic pain, if you look at their body, you examine them, there is no sign of inflammation, injury, infection, but they are in life disabling pain. What happens? What is the difference between acute pain and chronic pain? In acute pain, there is a tissue injury or inflammation that leads to excitation of pain receptors in the organ system wherever this thing is happening. From there, impulses are carried through our sensory nerve to our spinal cord, and from there they go up in the brain where they are interpreted and a response is generated, whether to withdraw, seek help, or whatever needs to be done. Without this system, we will suffer heavily if our system does not tell us where the pain is and how bad the pain is, we will be prone to a lot of injuries. So the purpose of acute pain is to make you aware and minimize the damage and ask for help. So what happens in chronic pain when the tissue injury is resolved? what is there. Every chronic pain starts with acute injury. Now, what happened to this acute injury and how we handle it, that determines what is our likelihood of developing chronic pain. Anybody who has a pain more than 3 months in a given place or a given region has a, by definition, chronic pain. After the acute injury, there are certain changes which happen in the tissue itself, whether it's your back, your hip, or your knee. There is some changes happen. Those are the receptor changes. Your receptors become super sensitive, even with stimulus, which is sometimes below threshold, that excites them and they send impulses to our nerves. Then our spinal column and the nerves, they also become supercharged and super excitable, and they also conduct these impulses as a priority at a faster rate. In your brain, the areas or the centers where this pain is interpreted, those also become super sensitized, and they keep on interpreting this pain without evidence or without there is any kind of tissue injury. So you see, there is a supersensitivity in the receptor, in the nerve, in the spinal cord, and the brain. That is a perfect recipe which start this cascade of chronic pain. Why this thing happen? It is not very clearly known, but we know for a fact these are the changes which happen once you have chronic pain. And this chronic pain makes your brain very malleable. Different parts of the brain are directly under control of this painful stimuli. Our brain, by and large, is an organ to perceive or get information from external environment or our internal environment and then interpret it and create a response. The area which makes this determination is our prefrontal cortex right behind your forehead, and that is the area is shown becomes supercharged and all the cells in this goes down. So your capability to make a reasonable rational decision decreases. Then the pain pathways, when they are going up to the brain, they pass through an organ which is kind of a router, as we have for our Wi-Fi's in our home. The whole sensory input goes to our thalamus, and that gets distributed to whole brain. That is the router of our brain. That also become supercharged, and then it becomes altered, and it continue to amplify the painful stimuli. Then the areas which are directly involved with emotions, whether our amygdala, which is our fear center, which is constantly scanning our environment, that becomes hyperactive. Hippocampus, this is the area which is needed to make memories. All the cells go down. That leads to memory loss. Then, last but not least, the feeling of satisfaction, the feeling of fulfillment, that comes from insula and the anterior cingulate gyrus. These are the other parts in the brain. They also get hijacked. So you see, in chronic pain, it is not a benign process. Whole anatomy and physiology of this whole system, starting with the receptors, sensory nerves, spinal cord, pain perceiving center, router, memory, emotions, all are effective. So the net result is you are physically disabled, emotionally you become irritable and different, which we will discuss right after this. You lose memory, and everything is exaggerated, and all the things, your ability to act cognitively, to understand, rationalize goes down, your memory goes down. That makes this whole process so complicated? Because any treatment which we will discuss, it needs to consideration of this pathology. If we do not understand this cascade, then you will not understand the treatment and you will always have difficulty in accepting the kind of treatment which you offered. Most of the time, people are in pain, and I understand you're in pain. Pain medication is not the only way to resolve the pain. See, so far, what we discussed, there is no stimulus, there is no tissue injury. Pain medication, especially narcotic pain medications, have a very limited role. And I think this is a good place where we should open up what are the treatment modalities which are open, were available. We need to hit all possible places where things goes wrong, starting right at the receptors, having nerves, spinal cord, router, pain interpretation, sensory cortex, all these areas, the medication we need to use which work differently on this one. And none of the treatment modality give you more than 10 to 20 at the maximum 30% relief. If you're taking a pain medication, especially narcotic pain medication, it's not going to lower your pain more than 20 to 30%. If anybody try to lower your pain more than 30 to 40%, 20 to 30%, they are going to lead to complications and you will have problems which we will discuss. What are the other modalities? Anything which makes our receptors, nerves, and the brain less sensitive to painful stimuli is the second modality. Third, local treatment from where the pain is originated, whether it's exercise, heat, cold, massage therapy, chiropractor manipulation, anything which can locally modify the stimulus is the next place where it could happen. The pathways for chronic pain and depression are the same. Anybody who is in chronic pain will be depressed, and anybody who is depressed can have chronic pain. So your evolutionarily, your emotional system is hijacked by pain. So what that happen is antidepressants have a lot of role in trying to lower the sensitivity of this pathway. Not one modality will work. As a patient, you need to understand this process, and we are going to go over detail about each modality. You must accept multiple modalities so that you have a more than adequate pain relief and you could function. Whenever we talk about chronic pain, what are we achieving? Pain relief is not the goal, because anybody who is just trying to achieve pain control, they are setting you for failure. As I said, in spite of best treatment, all modalities combined, goal is not zero pain. Our goal here is three: your comfort, your function, and your safety. We need to make sure you are comfortable enough, not zero pain. There is a threshold above which your pain is unbearable, and there is a threshold you could live with that. Just below that, that is the sweet spot part. Function. Pain medication must make you, or any kind of modality, must make you more functional. You should be able to take care of your activities to what it takes to live and maintain. You should be able to, depending on your function status, able to help your with family events. You should be emotionally controlled. You should be cognitively, your thought process should be intact. So you goal is your function. These any kind of treatment modality for chronic pain, we must improve your function and not pain. If your pain medication make you just zombie and you are sleeping whole day, we are not meeting the cardinal goal of pain treatment. Third is your safety. It is very important to understand senior physiology. As we get in those golden ages, there is significant changes in your physiology. Your body cannot handle what it was able to handle one time. Whenever you take anything in your body, there are two main sources from which it comes out. Your liver either has to metabolize it out or your kidneys have to filter it out. Other are sometimes in feces and sweat and breath, but majority of all medication, not only medication for chronic pain, all these medications are eliminated from your body through liver and through your kidneys. As we go through circle of life, your liver function, your liver test may be normal, but function of your liver to meaning or measured in terms of eliminating this medications decrease. Also your kidney functions, they decrease. Coupled with your decreased circulation, you are at higher risk for developing ulcers. Medications, when we talk about pain medication, they fall under two categories. Non-steroidal, meaning those medications which are not narcotic, they are anti-inflammatory medications, and narcotic pain medications. Anti-inflammatory medications, they are very harsh on your kidneys and they can put you at higher risk to develop ulcers. Most of our seniors have other medical comorbidities that they require certain medication which interact with anti-inflammatory medication, whether it's your blood thinners or your aspirin, or you already have history of ulcer. That makes using anti-inflammatory medications very difficult in seniors. Plus, if you are given narcotic pain medication, they lead to increased memory loss, lead muscle mass, decreased testosterone or estrogen in case of female. They interfere with every other organ system. They slow your heart rate, they decrease your blood pressure, which makes you for higher risk for falls. So that makes narcotic pain medication treatment very, very complicated. So when we are treating you or any other physician who's treating you, he's in a constant dilemma to keep you safe. So three cardinal goals. Your comfort is important, but that's not the primary event. Number two, you should be able to function better with this treatment. Number three, we must do plus and minuses and must ensure that your pain medication is not interfering with any kind of your functions. Then there is a unholy triad which happen with everybody who has chronic pain. Chronic pain leads to difficulty in sleeping. That leads to being tired all the time, leading to more pain medication, one or the other, more complications, and this cascade keeps on going. Ultimately, it is leading to pain, sleep disturbances, mood disturbances, memory disturbances. And we are in this cycle. And how do we get out of this cycle? That's what's coming up next. If 50% of us are in a moderate to severe pain all the time, we must understand chronic pain one for all. Next question is, what are the common reasons for this chronic pain? Remember, in this talk, we are not discussing about cancer pain. We are not discussing about end-of-life pain. We are talking about degenerative pain or any stimulus which was acute sometime now has become chronic. Osteoarthritis is the number one reason for chronic pain. Osteoarthritis is not in actuality a disease. It is the wear and tear of the articulate surface of the joints. Most commons are your knee, your hip, your back. That will cover about 70-80% of the patients who have chronic pain. In my word, anybody who is old enough and has arthritis is a privilege because that is a victory against aging and disability. But at this time, the goal is different. We must come up with a safer way to treat, and that's what's coming up next. Next is all rheumatological diseases, and the biggest one is rheumatoid arthritis. Rheumatoid arthritis has a two peaks. One is in the young adults, and second is in seniors. So, rheumatoid arthritis peaks twice. The hallmark of rheumatoid arthritis is symmetrical both side pains which involve both sides, whether it's hands, your feet, both shoulder, both elbows, but it's usually symmetrical, associated with severe morning stiffness. As you recall, when you get up, you're stiff. When you start moving around in 10-15 minutes, your body gels and you're able to go. But in case of rheumatoid arthritis, you have a significant amount of severe stiffness, which takes 40 to 60 minutes to help. Next common condition in the back is spinal stenosis. In spinal stenosis, the places or the openings from the spinal canal from where your nerve come and go to your lower extremities, those gets narrow and they pinches on it and you are not able to get adequate pain relief. And usually you present is that you tend to lean forward because what you're doing is you are opening up those narrow openings in the spinal canal, and where your nerves are not getting pinched out. You will find that when you go to any supermarket, you want to have the shopping cart and you're leaning forward on that. So that is a possible symptom of spinal stenosis. We call neurogenic claudications. Next condition is osteoporosis. In osteoporosis, your bones are becoming softer. Primarily, it doesn't give you symptom directly, but some people do complain of vague stiffness, vague aches and pains, but it can be significant if it let go for a long time. Currently, everybody above the age of 65, all females above the age of 65, possibly should be screened with bone density test, and every male above the age of 75 should be screened. Next, in our communities, diabetic neuropathy is the very important reason for chronic pain. And about 20% of the population who are diabetic, they get chronic this neuropathic pain. Chronic low back pain, which is lumped into whether it's involved the muscles in the back, ligaments in the back, facets, or herniation of your disc into the spinal canal or irritating the nerves is affects about 25% of your patient population. Fibromyalgia. This is a condition which is very difficult to diagnose and very difficult to live with. In this condition, you have a tender spot symmetrically at multiple parts of the body. We have done all the tests. We cannot find any possible explanation for that. All the tests for rheumatological diseases and other degenerative diseases are negative, but you continue to have pain. Next is peripheral artery disease. This is the disease where you have blocking of the arteries which are supplying your limbs. If you have significant amount of blockages, you could develop chronic pain from that. And then the last one is the cancer pain. But the question comes in is why these conditions are more common in elderly. It is not anything that elderly are cursed to develop this thing, because these are the degenerative changes which have accumulated over the period of years based on how we lived, and also certain things like osteoarthritis and possible osteoporosis happens by because we are in that circle of life. I hope with this you are getting insight into the reasons for your chronic pain. But most of them, as we go along, we will find it out. We need to have significant improvement in that, and we should be able to live properly. Now, the question comes in is how do our seniors live with this, and what kind of impact you have with this? With the neuroanatomy background, which I explained to you, you will find physically you're constantly in pain. And I have went over and over, the goal is not zero pain. So we are left with significant amount of pain in the end of the day. that leads to physical disabilities. And most of the time, senior tend to decrease the activity. They tend to limit the amount of activities they want to do because it's painful. Decreased physical activity leads to loss of muscle mass, developing of more osteoporosis, leading to more disability, and this cycle keeps on going. This is where your lifestyle, physical therapy, exercises will come a lot into play. Next, emotionally. I have explained you that in this case, our pain is hijacking our emotional system. It's so very difficult to live with pain and to live with somebody who is in chronic pain because they seem to be extremely nervous, irritable, and depressed. It's not your fault, but I'm taking you through the journey so that you understand what are the symptoms you may have. This is not a rule that you allow all these symptoms, but your caregiver or yourself will also be able to understand these symptoms. Cognitively, you will not be able to think clearly, rationalize, and make proper decision. This leads to interference with the relationships, and the burden on the caregiver increases significantly. Now, suddenly you are in pain and need help, but at the same time, from your mouth, you are spitting out vinegar all over, leading to difficulty in relationships, inability to think clearly, and leading to this cascade. How do we prevent that? I wish we would have a blueprint to live a clean, healthy life. When we are young, we are invincible. If anybody should get from this podcast is, which is coming up next, is regarding how we should have done differently and what we're going to do now. It has significant impact, both financially and also emotionally, psychologically, socially. Chronic pain is the number one reason for doctor office visits, procedures, and also hospitalizations. It is estimated that about 55% of the seniors who are living in any kind of institution like nursing home, assisted living, they have lifestyle limiting chronic pain, which is huge, and it is a lot of pain and suffering. How do we diagnose chronic pain? Chronic pain starts with acute event. Then those changes both in receptors, nerves, spinal cord, brain, and different parts involving your memory, emotions, and your thinking, all these things get hijacked. Most of the time, if you have a chronic pain and you have not been worked up, your physician will go through blood test and then focused examination, and the test based on what are the different etiologies he's considering based on your symptoms, like whether you have osteoarthritis, rheumatoid, fibromyalgia, spinal stenosis, herniation of disc, all these symptoms. So your tests, history, and examination will be tailored towards looking into these etiologies, confirming the diagnosis, and try to limit its effect on you. Now comes is the point here is, if you already have a chronic pain, what do we as physician do? What is our obligations? And this podcast idea started when one of my patients became very angry because I was not writing the amount of pain medication he was trying to asking me to write. We fully understand you both physically, emotionally, and cognitively. But from physician's perspective, my goal is to comfort you, keep you safe, and keep you going. And we need to have multiple approaches to help you with the chronic pain. One, we start from the site where the pain coming from. Anything which we could do locally, whether it's a knee pain, hip pain, back pain, spinal stenosis, we go after the reason you're having a pain. If it's surgical, medical, anything which we could offer you, we will do that and try to eliminate your pain. Unfortunately, even after treatment, you are left with significant amount of pain because these treatments many times they are not curative. So physical therapy, exercise is very important. More you will keep these muscles and joints and ligaments and tendons moving, better you will get it. So local treatments, physical therapy, and exercise. Now comes the transmission of all this faulty or phantom stimulus which are going up in the nerve, spinal cord, and brain, something to stop that. And many times those are anticonvulsant medications like Tegretol, gabapentin, Lyrica. They are very effective. Next, anything which can alter your perception of pain, meaning antidepressants, especially one class of antidepressant we call NSRIs, or the older ones, tricyclic antidepressant, they are very effective in helping you pain. In seniors, tricyclic antidepressants have a lot of side effects, and most of them are on Beers criteria, meaning Medicare publishes every 2 to 3 years list of unsafe medication which should not be given to the seniors. And most of the tricyclic antidepressant like a previous one, amitriptyline, doxepin, all those medications, they are on that list and they have a lot more side effects, and we don't use it anymore. So we are left with SNRIs, so which is duloxetine, venlafaxine, Prestige. All these medications are very effective to alter the perception. Then comes the mother of all problems is the opioids. Opioids, as I mentioned, they are helpful, but I think they need to be explained. No matter how much pain you have today, if you are taking pain medication, your maximum chances of relief from that point is about 30%. If you between 0 to 10, if your pain is 10, and no matter how much narcotic pain medication you're taking, unless somebody knocks you out completely, you could expect your pain level to come between 6 and 7. It's not going to happen beyond that. That's why you should accept other treatments, multimodal treatment for the same. Next comes in is how do we keep you safe when it comes to narcotics? Narcotics are not free. They affect your memory, they slow your heart rate, they decrease your blood pressure, they give you constipation, they lead to acute changes in the brain, making you more confused and making your sense of perception altered and increasing the risk of fall. And that's what we are trying to prevent of harm to you. So narcotics are not free from side effects. But how do we know objectively? That's what I want to explain one of that patient, what he was asking. We can kind of quantify how much narcotic you are taking, no matter whether you're taking hydrocodone, oxycodone, or fentanyl patch, or methadone. We convert into morphine equivalent. Just simple rule of thumb is hydrocodone for 1 milligram of hydrocodone is equivalent to 1 milligram of morphine. If you're taking oxycodone in any shape, 1 milligram of oxycodone is equivalent to 1.5 milligram of morphine. And you could keep on going. But these two drugs, and tramadol is equivalent to zero point 0.5, but half milligram of morphine. No matter which way you are taking, if you are taking hydrocodone 10 milligram prescription, which is the most common, 3 times a day, you are taking about 30 milligram equivalent to morphine. That is significantly lower than 50 milligram threshold of morphine equivalent for your safety. As a physician, my goal is to keep you safe first, comfort second. When people are taking astronomically high doses, especially when they are taking more than between 50 to 100 milligram equivalent to morphine equivalent, all cause mortality goes up, your risk for falling goes up, your risk of accidental overdose goes up. And that is a major issue. Second, people are very reluctant to get a prescription for naloxone. Many of our patients are on combination drugs. People with chronic pain, they tend to be more irritable and anxious. They are the one who are on anti-anxiety medication, which we call benzodiazepines. When you're taking one's brain depressing medication and you're taking pain medication, that makes it double whammy on your brain. So you may be taking 30 milligram or 30 milliequivalents equivalent to morphine, but you are taking other medications which are suppressing your brain, and that will increase to all complications which I just now mentioned. So people who are taking anti-anxiety medication and narcotic medication, they are really at high risk for complications. Why Narcan is very important? Because if, God forbid, you develop opioid overdose accidentally or intentionally, that could be lifesaver. If you are on pain medication, you must have Narcan prescription on hand, and everybody in your family should know. If they suspect anything wrong with you, they should score 1 into your nose, call, and they initiate 911. And if you happen to have go back, relapse into the symptoms, use second one, and hopefully by that time EMS will be there and you could be transported to the hospital and kept safe. In the United States, it is estimated in 2017 we lost 37,000 patients to prescription drug abuse. Those people were given pain medication for right reason, but accidentally leading to situations where they could not be saved. That is why now Narcan is over the counter. Every day I get so much pushback from my patients when I want to give them pain medication, if they are for writing your pain medication, to have a prescription for Narcan. Now I want you to understand this could be lifesaver. There are multiple standardized tools which we use to assess your pain and also your functional status and also your emotional status, anxiety level. And if you have a history of previously prescription drug abuse or any recreational substance abuse, you're alcoholic, that increases the likelihood of overdose and leading to complications. And that's why when you go to physician's office, every visit we ask you the same question. Is it helping with your pain? Is it improving your functional status? Because without these cardinal goals, we do not know how to interpret your symptoms. I have done this experiment every day in my life. You ask the patient, how's your pain? They will say 10. I had never had anybody who's saying pain is less than 10 because it's a subjective perception. But we need to come to how it's affecting your body, how it's affecting you emotionally, how it's affecting you cognitively, and how it's interfering with everybody around you. Next class of medication is anti-inflammatory medication or non-steroidal. I went over them in detail. Then alternative therapies. Most of the states have approved marijuana that has a use if used properly, medicated properly, and you're using it for right reason. Physical therapy, acupuncture, chiropractor manipulations, all these things, massage therapy, hot shower, cold shower, whatever it takes, they all work. The key message here is you have physical therapy, exercise, one bucket, medication which is working on your nerves and brain, that is the second bucket, antidepressant is the third bucket, Opioids, fourth bucket, anti-inflammatory medications, sixth bucket, and alternative therapies, seventh bucket. Your food has a lot to do with how much inflammation you have. Make sure your food is balanced, primarily fruits and vegetables, quality meat, quality fat, whole grains. You will lower amount of inflammation in the body and your pain will improve. Sleep, social stimulation. Make sure you have meaning and purpose to get up, even at the very old age. I have a patient who is 93. I saw them, both of them, couple of days ago. They are at 93 trying to learn a new language. You know, that gives me so much of joy. They had a meaning and purpose. And even at very, very late age, you must have meaning and purpose, reason to get up. As Nietzsche said, if you have why, you will figure out how. You need to provide yourself why you should get up, why you should go through this pain and suffering to live, and you will find how. I hope this discussion has provided you with significant insight into that. All these modalities, they are contributing to 10 to 20% in pain relief. Open your mind, accept all forms of treatment. That will control your pain barrel, will minimize the side effects, and will keep you safe. Like in every podcast, we go through most important question on that topic. First question is, what are the most common causes of chronic pain? Low back pain, knee pain, hip pain due to osteoarthritis, osteoporosis, rheumatoid, spinal stenosis, fibromyalgia. They make, and chronic low back pain make the bulk of the patients. Few of them are because of we are going through a circle of life and our body has become old and we have a lot of accumulated, lot of degenerative changes. Next question, how we diagnose chronic pain. Chronic pain is based on your history, examination, and focused pertinent tests. What are the best treatment options for elderly? Multimodal. If we are trying to maximize only one medication, whether it's physical therapy or exercise, medication, anticonvulsant, which is working on the nerves, antidepressants, opioids, non-steroidal, we need to have combination of all of them on the table based on clinical scenario. We should not try to maximize on this one. Start slow, go slow, keep this side effect to the minimum. Next question is, how does chronic pain affects mood? Chronic pain hijacks your emotions. It makes you more irritable. It makes you anxious. It makes you more depressed. Next question, what are the non-pharmacological treatment or how can I treat my pain naturally? That is anti-inflammatory diet, which is a balanced diet, predominantly fruits and vegetables, quality fat, quality protein, and whole grains. Next question, what is the role of exercise? Exercise leads to production of endorphins, which are natural painkillers in your body. It has a significant role. Next question is, are there any specific guidelines by CDC regarding chronic pain treatment in elderly? Absolutely. They have come up with evidence-based proof that opiates are not the only medication which help. And actually, they have gone to the length to demonstrate that opiates might be harmful in seniors if used injudiciously. We should limit the least amount of medication which could get by. What are the most common side effects of opioids? We will start from head to toe. It can make you more confused, disoriented. It can interfere with your ability to rationalize. It will interfere your memory. It will decrease production of testosterone in case of males, estrogen in case of females. It can increase prolactin. It can lead to increased osteoporosis. When it comes to musculoskeletal system, it will increase the risk of falls. In your GI tract, it will lead to constipation. In heart, it will lower heart rate and decrease your blood pressure, again leading to passing out and increase risk of falls and fractures. Kidneys, they interfere with the excretion. Also, they lead to multiple other non-specific changes in the brain and body that they can really affect every organ system. They decrease immunity, make you more prone to infections. Can chronic pain be prevented? This is a very loaded question. Absolutely, this can be prevented. But I think in this talk, we have reached the circle at the stage of circle of life where we already have established. But for young guys, if we lose weight, regular exercise, proper diet, regular sleep, learning some new skills, all these things lead to better life and prevention of not only chronic pain, but rather all chronic complications and diseases. Next question is, how does chronic pain affect sleep? I guess if you are in pain, you will have difficulty initiating pain, sleep and maintaining sleep. And our seniors end up consuming over the counter lot of medications like Tylenol PM, Benadryl. All these medications are anticholinergic. They make you more confused. They make you more risk for falling. So I recommend do not resort to these medications. Rather work with your physician to help you control chronic pain. I hope during this talk I have made it clear what is acute pain is, what is chronic pain, what are the changes which happen in the brain, how does this affect you both physically, emotionally, intellectually, socially, and then how to live with it and how your caregiver has to change and make adaptation to live with you with this chronic pain. Role of physician, and the most important thing is it is not one class of treatment you should expect. I request all my people who are listening to this, widen your horizon, accept different modalities because each modality has a fixed percentage of relief it can provide you, no matter how high you go on that. With these words, I want to thank you for your kind attention. My name is Dr. Kulmeet Kanlas. We have a YouTube channel, Kanlas MD. Please like, share, and subscribe to our channel, and we will see you in next video. Thank you very much.